This is a case of a ruptured basilar apex aneurysm treated with surgical clipping. You can see the small aneurysm here. It was blister-like. Coiling was attempted but unsuccessful, thus she was taken for surgery. We elected to perform a trans-Sylvian pretemporal approach, perform the craniotomy, and here we're dissecting the arachnoid over the optic nerve. Continue our dissection and identify the internal carotid artery. We then turned our attention to the Sylvian fissure, which has to be widely split in order to use this approach. The Sylvian fissure was very thickly filled with blood. To retract the temporal lobe, bridging veins from the temporal lobe to the sphenoparietal sinus must be coagulated and divided, which is generally well tolerated. And after this, the temporal lobe can be retracted posteriorly and laterally to widen the pretemporal space. And a key part of this approach is also mobilizing the uncus off the lateral aspect of the carotid artery. Here we're peeling the uncus back off the intrachoroidal artery, and here we start to see the third cranial nerve, which enters into the oculomotor foramen. And we're working here along the tentorial edge, widening this space. With dissection of the Sylvian fissure, we can also view the carotid bifurcation, and the retractor can be repositioned as needed to widen this working area. The next step, we identified the posterior communicating artery and followed this to the P1, and here we see the P1-2 junction. And following this, we started to work medially towards the basilar apex. And obviously this area is very dense with perforating arteries, and here also thick with subarachnoid blood, which made this work somewhat challenging. We split all remaining arachnoid adhesions to widen our working area. You can see the view here. And now we turned our attention to identifying the basilar trunk. We're working through subarachnoid blood, and the residual liliquous membrane was divided. And eventually, after working through a significant amount of blood, we identified the basilar trunk, which you can see here. Following this, we worked along the P1 segment, and we started to identify the aneurysm, which had a fair amount of fibrinous material consistent with recent rupture. Here we're lifting up some of that material to identify the neck on the near side. We can also see the P1 joining the basilar apex. Here we're gently dissecting in order to expose more of the aneurysm. And here we're dissecting to visualize the connection between the basilar apex and the P1. See a perforator at the base of the aneurysm there. Here we're dissecting over the top of the dome, and on the far side you can see a more normal appearing aneurysm. On the near side appeared to be the rupture point, which again is covered with fibrinous material. And being a small aneurysm, this was a relatively straightforward clipping. It was clipped with a single slightly curved clip. After the initial clipping, this was readjusted to gather more of the aneurysm. We were careful not to cinch it down too tightly, as there was a perforator at the aneurysm base. ICG angiography was performed that demonstrated filling of that important perforator and no filling of the aneurysm. And this is the final view prior to closure. You can see there's no significant retraction injury on the temporal lobe. This is the post-operative CT angiogram demonstrating no residual aneurysm. Thank you for your attention.